Thank you. Hi, this is Nate Laxman. I'm a partner of Sullivan Gardner and chair of our telemedicine and digital health industry team. My apologies for not being on the screen visually right at the start of this. My internet went down and I'm not exactly sure what's going on. So in any event, it is my personal pleasure to host Gina Bertazzi, CEO of KindBody, and Nicole Boskoski, Vice President at Parsley Health. Two companies doing very innovative things using telemedicine and digital health, virtual care technologies to not just use it for the technology itself, but to in many ways fundamentally change the way that individuals receive medical care and the user experience associated with it. And Gina and Nicole, welcome to the program.
Hello.
Thanks, Nate.
Thanks for having us.
I'd like to have some open discussions here, so I'll tee up a series of questions, and y'all can field them and have a little bit of back and forth, and the attendees will be able to enjoy some of your perspectives. And we'll start with the first one, softball, because it's COVID related, really, but how has COVID affected your strategies for using virtual care? And let's start with Gina, please.
Yeah, thanks, Nate. Gina Bertazzi, founder and CEO of KindBody. Thanks for being with us today, and thanks to Foley for hosting us. We're fortunate at KindBody, where we are reinventing family building and women's healthcare, to have first started with technology. We believe fundamentally that you can only change healthcare by first investing in technology, and then second, you have to be in the provision of care. You have to be in the care delivery business, instead of too many other businesses today or apps or care navigation or utilization management overlays to the already incremental waste that adds up into the system to higher cost to employers and the consumer. But so at KindBody, again, we believe in starting first with technology. That means we own our own patient portal, our own electronic medical record. We have our own engineering team, our own product team in-house. And so we were fortunate when COVID hit in mid-March that we already had our virtual platform, that we already had patients engaging with doctors early on. Certainly what COVID did was accelerate that. And what that means is we moved every single fertility assessment, any kind of women's health assessment, to online. Frankly and candidly, what that allows healthcare businesses to do is operate more efficiently. Is you can actually see more patients in a condensed period of time if you're not having to wait for them to arrive and wait for them to leave. And that's true not only of our consumers, but it's true of our providers as well. So we're incredibly blessed, again, at KindBody, to think digital first, patient first. What COVID did was, again, accelerate our business. So
it's great. And then I'll pick up off from there. Nate, if I'm very honest with you, I think that the biggest change of COVID has been that everyone has become much more comfortable with the types of AV issues that you're experiencing with Zoom or dialing in or internet issues. So that's, I think, the one most important thing that COVID has done for us as a workforce. In terms of first who I am and who I represent, my name's Nicole. I am our VP of Clinical Operations at Parsley Health, where I oversee our human services side of the business, which includes all of our clinical staff, our amazing operators, member experience operators, and the folks who are delivering on our internal sales function. So for those who actually aren't familiar with Parsley, I'm assuming that you all know who we are. We are the first digital health service designed to heal chronic illness and optimize on healthcare for those approximately 150 million Americans who are struggling with at least one chronic condition in this country. And when we think about COVID, so taking myself back to March 13th, when the world felt like it was on fire, we had spent as a business the prior 6 months actually building a telehealth practice and service. We had come to realize very early on in our journey as a business that in order to expand our accessibility and in order to reach more people and transform the health of everyone everywhere through what we believe is the world's best possible medicine, we had to go virtual. We had to meet people where they were. And the realities of our business was that standing up flagship locations in cities across the country would take far too long of a runway for us to deliver on that mission anytime soon. So we had already started delivering on the telehealth practice and promise. COVID accelerated everything that we were doing in that world anyways. It sounds like it's done for Gina and her business with Kindbody. So we were a practice that was serving about 10 states nationally. We're now a national telehealth provider in nearly every state, including DC. We've 20x'd our virtual service and offered members a new lighter touch product to meet them where they're at in terms of both their accessibility from a telehealth practice perspective and from a cost perspective. It's a lower price point product. So I think as a team, what COVID forced us to do is really define who we were, define who our customer was, and then pour gasoline on the fire that was already this transformative piece of our business, which was telehealth.
Gina, could you, I love how you talked about using technology or health technology in one otherwise simple way, right, to significantly manage the throughput and increase efficiencies and productivities. Is there another way that Kindbody used any sort of virtual care technologies in connection with the last 6 months pandemic?
Yeah, sure. What's critical and the biggest challenge, what's critical at Kindbody and the biggest challenge that's existed in healthcare is even if any of your doctors are on a technology system, none of the systems talk to each other, which means the online incoming scheduling form does not integrate with the EMR, which does not integrate with the billing and collections. And so that's what causes all this fragmentation. It causes all the waste. It drives up cost. It drives up wild inefficiency in the system. And so as a women's health and fertility care company, we are actually the only fertility clinic in the entire country that allows for online scheduling. So all other patients looking to book an appointment have to use the telephone to pick up and call. Often you get voicemail, they call you back, and then there's this, again, waste in the system of telephone tag. So even when outside of the fertility industry, let's assume that they have some sort of electronic scheduling system. Patients today, by the way, expect to be able to book online. You book your Soul Cycle and your Dry Bar, you book everything else online. But when that appointment comes in, maybe, hopefully, you're filling out your form, any of your patient records before you arrive, because I just went to see my local OBGYN out here and I had to fill out paper charts. I'm like, but you'll make an error. You'll get the wrong gender, you'll misspell my name. Like the human error in medicine and healthcare has to be removed. But it also, not only does human error have to be removed and replaced with technology, but the systems must talk to each other to create true efficiency. And really, I'm talking about efficiency as a CEO, but what our primary goal is to have a seamless member experience. That member experience is just bad when you ask somebody to fill out 5 pages of paper. It's bad not only for the member, again, it's bad for your staff. So again, the seamless member experience in COVID, again, our members, we primarily see folks in the age of 25 to 45 years old. Those people have a tendency, they're all digital first. So we don't see any apprehension of them going in, logging in, creating their own patient account, patient portal, entering in their credit card. They are accustomed to this seamless member experience. I think where the challenge comes in is if you presume this is your experience, it is wildly unusual in healthcare. It is the member experience that you should expect. It's how you book a restaurant. It's how you book your flights. It's how you book, again, your Soul Cycle or anything else, but it does not happen in healthcare. And at Kindbody, we thought about that early on, is how to have a seamless, easy to use member experience.
Yeah, and
Gina,
and member and users and consumer. And Nicole, you had mentioned in your response, like I think customer or consumer. Both of you came from, maybe it's a hospital and a health plan where they use also different vernacular when referring to people. So Nicole, let me hit you with this one, which is really an extension of Gina's line of discussions. How, in your opinion, how will this new direction of a consumer-oriented healthcare change the patient experience? What does it mean for virtual care? And how is Parsley in particular really harnessing that patient as consumer experience to your advantage?
Absolutely. And for those who may not be quite as familiar with my background as you, Nate, I've been at Parsley for over 3 years now. But before that, I spent quite a bit of time at Oscar as an early member of their team, building out their insurance operations, membership experience, and care delivery practices. So I've had a lot of time building digital health tech solutions designed around the member, right? So this idea of the customer as a member of your practice is ingrained in me. I know that's not how a lot of healthcare works. So I think that when you look at the payer side, what the payer is of course, most of us know what the payer is incentivized by is outcomes, right? It's all about getting to better patient outcomes. It's about reducing the cost of care, and it's about delivering a better experience that creates engagement with your product such that members are sticking around. And increasingly, I mean, in this country still, insurance is largely offered through the employer. So employees don't have much of a choice of who they have to in terms of payer. But when they do have a choice and they have engagement, you see that they're able to commoditize on that in future product choices, especially as those folks move to other employers and make decisions about who their payer will be, who their benefits provider will be. So when we think about those outcomes, I think that what you're seeing is that increasingly these are services like Gina's around infertility and women's health, Parsley around chronic conditions more holistically, including autoimmune, GI health, cardiometabolic health, is that you're seeing that patients who engage with these services, they are delivering better health outcomes. They are both feeling better, but they are actually costing the system less. So just to give you a quick example, at Parsley Health, each patient is paired with a health coach who guides their journey, and then one of our board-certified clinicians who is their investigative journalist in understanding their specific care plan and approach. And so this sort of care team is actually directly leading to better outcomes. For example, we had a member, she was a 19-year-old transgender woman of color. She went to dozens of doctors. She recently messaged us on social media with her story. She had attempted to get to the root cause of her chronic fatigue, GERD, and recurring infections. All of her pre-doctors, she had gone to over 10 of them. Think about healthcare costs in the system, right? You're starting to talk about 10 specialists, multiple visits. Each of them is a couple $100 to the system. None of them could figure out what was happening. And they missed the signs that she was suffering from multiple nutrition deficiencies, subclinical hypothyroidism, and recurring viral infections. She came to Parsley. We listened to her concerns, ran a bunch of advanced clinical testing, and offered her a very clear diagnosis that then allowed her moving forward to reduce her prescription drug utilization by over 65% and reduced her specialty visits in the system. So when you think about the payers, what the payer really cares about, again, is that clinical outcomes piece, especially outside of the high dollar claims. You have a lot of being driven by prescription drugs and specialty care costs. And Parsley reduces both by engaging the member, by getting them a clear plan that they can implement in their day-to-day that's lifestyle-based, and that allows them to reduce their overall cost to the system. So as payers are starting to see this, you'll see more of this sort of member-forward framing in the creation of value-based arrangements because they work. They work in driving down clinical costs and they make people better. So it was a long-winded answer, but I hope the case study really, I think that's what speaks volumes more than anything else I could say.
Yeah, Nate, I'm going to jump in and tell Nicole and Parsley, I think that's absolutely right. What Nicole did a great job of saying is we got to get back to healthcare the way healthcare was designed, which is between the doctor and the patient. What's happening in the payer system in this country is the payer has shifted from the large carriers to the employers. So we've seen more and more employers move from fully insured to self-insured to do one thing and three things: improve member experience, improve outcomes, and control cost. And we would argue, my previous business was Progeny, which is in the benefits payer space, but you actually cannot effectuate change if you're not the clinician working with the patient. And so that's what's frustrating when you call the payers, the legacy payers, in the fertility space, it's Progeny, but the other payers are Cigna and United and Aetna. it's rare that they can assist you. They really love the telephone. They really love the hold button on the telephone. And what they're doing when you're on hold as the consumer is they're looking for a doctor. We have said, and what the employers have said is, let's get rid of all this waste and middleman in the system. I'll contract, the payer has now moved from these middlemen to the self-insured employer. I'll control for cost, and I'm going to negotiate value-based case rates. Nicole alluded to it, but I'm going to negotiate value-based case rates directly with my doctors so that I can, again, do those three things: improve member experience, improve outcomes, and reduce costs. But you can only do that when you connect the payer of healthcare. We would argue, again, more and more in this country, it is the employer. It's that commercially insured. It's different than fully insured. It is that self-funded plan that is contracting directly with doctors. And then you're really removing waste in the system because you're putting the doctor directly with the patient and the payer of the healthcare. So all of these other middlemen, and that's why you see so much consolidation in the industry, is that the middleman and the carriers that have historically existed to make margin, those incentives are not aligned. If you're making a margin on what your reimbursements for your doctors are, and that margin's 15 to 20%, and you call into the carrier's call center, are they going to steer to the highest priced doctor or the lowest priced doctor? If you're making a 20% commission, you're going to, 20% of a $20,000 fee is more than 20% of a $15,000 fee. So again, it's hard to, like what Parsley and Kindbody, and there are lots of others, those are two good examples, but we really are intent and unapologetic about removing waste from the system. And you do that by being in the doctor's office, like described.
Gina,
yeah, and I'll say too, to piggyback on that, Gina, just one quick point, Nate. We've seen a ton of inbound, especially in the last 6 months because of COVID and our positioning as this first national telehealth service for chronic conditions. We've seen a ton of inbound interest from employers who are specifically looking to offer something like our service, not only on a PMPM basis, which is historically how you've been able to offer something like a teledoc, right? You say, I'm going to pay you $10 per head on a per member per month basis, and you just indefinitely offer access to the service. They're increasingly looking to create blended arrangements that combine a PMPM so that like a business like ours has the predictability of the number of members that we're going to be servicing, but they want to see per utilization. So they're trying to build a blended arrangement where it's more of a PEPU, per employee per use. And that signifies to me that employers are starting to understand that in order to really impact their clinical claims costs, if they're self-insured and a larger employer, that they have to get employees to actually use the service. It's not just about putting in the fancy employee brochure and checking the box. People expect more now, and people expect more of their digital health solutions, similar to what you were describing earlier. Since they have at the touch of their fingertip, I can get food delivered to me, I have a car service ordered to me, they're expecting that sort of service from digital health as well.
Yeah, and Nicole, the same thing. I mean, we're seeing this new acronym, PUMPM, right? Per utilizing member per month, because the employers
healthcare loves acronyms.
Yeah, well, but the employers are very sophisticated. What they're saying is, listen, we're going to get rid of these legacy systems where I'm paying a PEPM or PMPM. It is rare that 100% of your member population suffers from anything. Not cancer, not infertility, not chronic condition, not cancer. And so what the employers have said is, listen, I need to help my member. I am committed to helping my member, but I want to pay for an infertility solution for only my folks who use infertility, for my chronic, and they really want to segment this audience. And so it's been fun to grow with these employers because they are they have as much conviction as Nicole and I share to really change the system. And it's nice to see because now the goals are aligned. Now they're working directly with doctors. I'm not a doctor, but we have doctors on staff. Our chief medical officer is Dr. Lynn Westfall, who joined us after 23 years at Stanford. She joined us January 2019, and it is rare. Trust me, if you go to doctors in health systems or hospitals, I've never met a doctor that says, pay me less, not one. And again, it's hard to align cost if you don't have doctors who are intent on removing costs from the system. Lynn Westfall starts every discussion with how we pull cost out of the system, but that's very rare for a doctor, and it's because it's a doctor in private practice. But again, the system is broken. Plus, in Nicole's situation and at Kindbody, our patients are relatively healthy. We would tell you that the hospital should be reserved for very, very ill patients. COVID patients, right? But if you have a gut issue, or if you have a nutrition issue, or if you have an infertility issue, the last place, respectfully, you should be is a hospital. And so that's really changed too, Nate, as you think about this consumerism of healthcare, and that is bringing care to the member, the consumer, where that member or consumer is. Our location in Manhattan is right on Fifth Avenue. It's retail. You can stop in, you can get your IUD in or out, or you could sign up for an IVF cycle. But it's instead of, again, waiting for the member, asking the member to come to us, we have to serve and we have to go where that member population is.
Let's unpack it. You guys, the two of you raised some amazing points, and I want to kind of go off script a little bit and unpack two of them. First is the PEPM, or I guess pump, or your new acronym or whatnot, right? But if you have and it's funny that I'm calling like a Teladoc style PEPM traditional, right? But if you have like a traditional subcapitated model like that, wherein you're theoretically as the provider taking on risk, but if in reality the utilization is so low as to never hit that threshold, then conceivably the plans may be just overpaying. Is that what you're saying, that they're getting smart to it, and that maybe the time of just a pure PEPM type of a thing is limited, that the plans are getting more sophisticated in their non-fee-for-service payment arrangements?
I think, when we think about plan design and how the carriers, they are getting better. Listen, I really do think all of the large carriers are, for the first time, thinking about innovation. They're adding digital tools. How they're pricing is still very much a traditional methodology. It is. You just see PEPMs, you see PMPMs, you see traditional pricing strategy. I do think where the pressure is coming from for the carriers is the large self-insured employers. And they are absolutely pushing this traditional model to go at risk. And it's easiest to start for the employers to go and their vendor, whether it's a hospital system or a industry vertical vendor like Kindbody and fertility. We know, Nicole mentioned it, but there's quite a bit of predictability to our business. We know actually how many of your member population is likely to suffer from infertility and need fertility treatment. And so we're not opposed to going at risk, because guess what? We can control costs because we price our own services, because we're in the doctor business. If I'm a carrier, the doctor sets his or her own price, and the doctor negotiates every 3 years their reimbursements. And many doctors in the fertility space actually sit out of network. And so it's just complicated. I do think the carriers are trying to rethink their pricing model. I think the reason they're trying now is at the request, or really the demand, of the large the large self-insured employers.
Yeah, and well, when you talk about, I would 100% agree with that. When you talk about earlier, Nate, this is after all a panel on COVID, the impact of COVID. COVID has had major impacts on payers this year, because they had the premium dollars that they were, had anticipated bringing in for this year. By law, they have to use some percentage of that. It's a fairly significant percentage, 80 to 85% of those dollars, out towards medical improvements for their population and or claims costs themselves, largely claims costs, obviously, in order to preserve their MLR. And so right now you have a lot of insurers who are sitting around looking at their balance sheet saying, oh crap, we have a ton of money that we're gonna have to pay back because no one went to get any sort of elective procedures or diagnostic procedures, or basically any healthcare that wasn't direly crucial in the last 6 months with COVID. And so what you're seeing, and part of the reason that you're seeing a lot of inbound interest to businesses like ours now, is that transparently there are payers who are looking to unload dollars from this plan year into companies like ours so that they can offer a benefit prospectively to their members next year, because of the fact that they have this massive delta that they have to make up for. Otherwise, they have to give kickbacks to their members. So that's a really unique opportunity for businesses like ours to take advantage of, and to open the door to conversations that historically payers have been reticent to taking on that sort of risk. It's, generally speaking, the party line would be join in network. Let's see how it goes for a few years. And then if you're really showing outcomes in our based on our claims data, then we'll talk about something that's more compelling and fair and mutually, value-based. Now you're seeing a really big change this year where all of these folks who are heads of clinical quality programming are reaching out to folks like us to talk about deals for next year.
I'd like to follow up on
Sorry, Nate, I want to give a quick plug. What Nicole is talking about, Reed Abelson, who is a reporter for the New York Times, did an excellent article on this. If you just Googled this article, she talks about these massive amounts of profit that these payers are sitting on now that they've got to either spend. Now, if you talk to the carriers, what the carriers would say is, listen, just because those claims have not come in the last 6 months, they're coming. So we can't give too much money of this away. Please don't think that the payers are too profitable, because we're not. Even though they haven't been, the services have not been delivered in the last 6 months, they're coming. And so, and these are multi-billion dollar organizations. So it's just the point, when you're that big, it's hard to turn that quickly. And I think that's, in their defense, that's what they're saying is, listen, we can't give all this money back because it is coming. And it's hard to argue with that, because I do believe people who postpone elective surgery have just done that. They've postponed it, but they rarely have canceled it completely.
That's right. So next year is going to be very challenging for payers who have pre-priced their plans as of 2019 for plan year 2021.
I love these discussions because they're more macro level that influence how care is delivered. I want to dig into something that's more micro level as a follow-up to something to Nicole you had said earlier. And I think for these maybe less nowadays with the acceleration of telemedicine due to COVID and whatnot. But there's still a large number of folks out there who think, when they think telemedicine, they think, look, there's only a couple of things you can do. Use an audio, video, and maybe an urgent care alternative, or these are like birth control or erectile dysfunction medicines through asynchronous, right? Can you tell me a little bit, unpack how Parsley, right? You took on a much more, it is still direct to consumer, right? But you took on a much more challenging or heavier lift clinically with chronic care. Tell me, like, practically some of the tools like labs, diagnostics, whatever that you use in this DTC virtual setting that allows you to handle more clinically complicated and robust medical services. That's the first one. And then the follow-up is, what kind of metrics are you doing to try to prove it out, to say, oh yeah, we are actually improving care? How do you track that?
Yes, absolutely. And I see some of these questions are also coming from a few listeners here, Terry, Michael, David, and George. So I'm happy to answer some of those, and I will do my best to answer both questions. But Nate, if I get off track at some point, please feel free to bring me back. So just to give this group a momentary view into the progression of Parsley over the last three to 4 years. Our first generation was just proving this clinical approach out, proving that there was a market for this type of clinical approach that we say combines the best of functional and holistic and conventional care into our own special Parsley brand of medicine. So to do that, we contracted with WeWork locations across this country and started operating our own locations out of these co-working spaces. Wildly successful. We got enough proof points quickly and early on to raise a Series A, and then spend the next year building out our flagship locations located in New York City and Los Angeles, respectively. And those locations are, over a couple thousand square feet, are able to service members in person, have on-site labs where you can get lab work done. Even today, all through COVID, we were open and able to see members in person for those folks who did need to be seen for more acute or urgent issues. Phase 3, which is what I've described, has happened over the last year or so. We saw that in phase 2, about 60% of members were choosing, after their first visit with a provider in person, they were choosing telemedicine anyways. No one asked them to do that. They were doing so out of convenience, and meeting them where they were at, we understood that it was critical for us to develop the technology and the product experience to be able to offer this sort of experience in the home, in the workplace, where people were, going somewhere to just talk to someone in person is no longer a requirement. You now have this amazing technology you can do it through. And then finally, our most recent expansion has been offering that same brand of clinical medicine we tested here all the way in generation 1 of Parsley in a shorter package that reduces the price point for members of socioeconomic groups that historically haven't been able to pay $150 a month for this type of care. So who we're targeting, I mentioned earlier, we're targeting the 90% of the 3.1 trillion dollars that Americans spend on chronic conditions in this country. There's over 150 Americans who are living with at least one chronic condition. When you think about what I've just described, a lot of these people are going to their primary care physician, to specialists, to be seen in person, and they're still not getting better. So why could we help them through telemedicine? We're not even touching them. We're not even seeing them. And the answer is that we, first off, all of our clinicians receive a functional training that's beyond the scope of what conventional physicians practice. It's crazy. Medical school students don't actually go through any nutritional training, which to me blows my mind, because so much of what your health is determined by what you eat. So our doctor, every single doctor in our practice has a background in this sort of practice anyways. But on top of that, we've developed a 12-week flagship fellowship program that every single provider goes through, wherein we teach them some of the more complex methods of how to administer this care and to really trace the member's history to understand the underlying root causes of whatever symptoms they're struggling with. So that's the first, is you train the doctor. Second is you give them a product where they can actually get to know the patient. The conventional space gives physicians roughly 15 minutes on average, and typically it's less time than that because the physician, is back to back to back, so they have to walk from room to room to see people. So 15 minutes is not enough time to get to know someone enough to say, hey, this encounter that you had 3 years ago, wherein you really struggled with this experience of chronic fatigue, that has actually been the predecessor to all of this other constellation of symptoms that you've since struggled with. So we give them time, we give them training. Third, we have advanced testing. So I mentioned that we have on-site labs in both New York and LA. We work with partner locations in an omni-channel capacity, Quest, LabCorp, BioReference, two or more conventional labs. But on top of that, we also have specialty labs that are not generally accessible to consumers direct. This includes core testing, GI testing, metabolic health testing, genetic testing. And we offer those tests in a customized fashion. So we don't give every single test to every single member, but rather after we get to know you as a member and understand what specific, let's say, cohorts of conditions or cohorts of symptoms you're addressing, we then will ensure that we test first before we treat. So we train you, we give you extra time as a clinician to get to know this person in front of you so that you can connect the dots in a way that no one ever has before, and we test. Now, in terms of how do we prove it? So that was a question, I think, in the chat as well, was how do we prove it? So Parsley Health collects an incredible amount of data on our patients' outcomes. We've been doing so since the origination of our practice. And that's what happens when you are founded by a physician who know the importance of clinical outcomes. So since day one, we've been tracking prescription rates and our ability to reduce the number of prescriptions that members are taking over the course of their membership with us. Like I said earlier, on average, 66% reduction in prescription drugs over the first year. We've also developed our own proprietary symptom index tracker, which tracks across 10 different symptom domains, symptoms being GI, mental health, autoimmune, et cetera. Your specific symptoms as a member that you're facing today and what frequency and severity they're happening with. Our clinicians are able to use that over time to essentially understand how your health is changing. And our members are filling this type of tracker on a regular basis. So, and that's in addition to, by the way, I didn't mention, we collect, the more traditional types of HEDIS scoring, lab value testing, those types of things are every institution largely is collecting them, although you'd be surprised at how many are not cataloging them. So across those two measures, we found that we've been able to reduce prescription drug costs. We've been able to reduce specialty care costs. We track reduced utilization just by talking to our members and asking them about it. And then with this proprietary symptom index tracker, which has gone through phase 3 clinical validation, is currently going through phase 4, we've seen disproportionately that members within, I think it's something like 90% of members will see improvements over the first 6 months of their membership. And improvement is defined here as their symptoms got better or their symptoms were completely resolved. So I think that answered your questions. But no, if I didn't, please let me know.
No, it's great. And I love how it shows very concrete, demonstrates that, like, for those who think telemedicine is just one-dimensional for comparatively superficial medical needs, it directly refutes it. Gina, let me kick it over to you because Kindbody is
and just a quick note there. Oh, sorry, Nate. Just a quick note there too. I will say, we recognize that there are things that we cannot do virtually. So for those members who live within one of our core geos, we would route them to a center and they would be able to receive care there should they choose to be seen in person. We also understand the importance of building that sort of omni-channel presence. So in key markets, we've started partnering with urgent care centers and directing our members to those locations because we recognize that if I, for example, as a member have a sprained ankle or I need sutures because I've cut my head open, I can't call my health provider. So just wanted to make that very clear. We cannot suture virtually yet. Please continue on with your question, Regina.
Hey, Gina, so the member for Kindbody is, I wouldn't call fertility a chronic disease, right? So they're looking for something a little bit different. How do you go about approaching sort of satisfaction or success, or how it is a better experience than a more traditional alternative?
Well, you measure it, Nate. You measure it. And it's interesting, again, when you leave a restaurant, how is your experience? I mean, people historically consumer-oriented experiences, again, whether that's travel or eating or anything else, they always want to know how they did. They're asking for feedback. In healthcare, you never historically got, how did I do? Right? And even if you got, how did I do? They didn't want to hear the answer. But we measure Net Promoter Score. We think about healthcare just like consumers do. Our Net Promoter Score today is 92. That is extraordinarily high and unsustainable in the healthcare industry. Now, in the healthcare industry, for some subspecialties, it can be in the 50s, 60s. In the carrier business, it has a tendency to be lower than that. We tell our physicians and others, we'd like it to stay kind of above the 80s, but at 92, we feel like it's unsustainable. But when the question is, how do you measure whether or not the customer is happy? You just got to ask. And so we send customer feedback surveys. They're usually just done via text. Please rate us on a scale from 1 to 10. But we believe we cannot get better unless we hear first from our customer. And our customer is always that member, a patient, a client, but we are very interactive with them. One of the other questions that came up in the chat too is this fragmentation that it typically exists between kind of the virtual provider and the on-site provider. It's really important to level set at Parsley and at Kindbody. We're the same. So we employ our own doctors. We're not a digital-only solution. At Parsley was founded by a physician. You heard Nicole mention that. We have a founding physician, Dr. Fahima Sassan, on our team. But that fragmentation is what we're looking to get rid of, that handoff that seemed clunky that says, because remember, it's clunky for a reason, because if I'm a virtual provider only and I'm a per diem OBGYN, but I'm not employed, I'm just looking to pick up some extra cash, it is highly atypical that whatever system I am using to enter in the data that says your PCOS or your endometriosis is ever going to be interoperable with that provider system. So at Kindbody, we employ our own physicians, whether that care is in virtual or in person, you still have the same care providers. It all sits within the same exact EMR, the exact same scheduling system. Now, us, again, very similar to Nicole and Parsley's business, we can't be everywhere at once. So we have a partner network of 200 other clinics around the country. that can provide service and high quality care in San Antonio or Chicago or other markets. So today, Kindbody has clinics in Princeton, New Jersey, in New York, and Los Angeles, and San Francisco. We're expanding to Seattle, Atlanta, and Austin the first half of 2021. So that's 7 great markets in the US, but arguably we need to be in 70. Because that's where it is clunky, right? When you call into the Kindbody call center, you use our scheduling tool, and we do hand you off to that practice in San Antonio. We know that overwhelmingly, I'm going to tell you something, what's this big aha? Women patients prefer women clinicians. More than 80% of the time, a female patient wants a female doctor. In the fertility world, it's overwhelmingly male doctors. So the question then comes up where the experience really is clunky is when we send you to San Antonio and you're sitting with a male doctor who may or may not be sympathetic or compassionate to your historical reproductive health needs. So it's not perfect. Both Parsley and Kindbody are well-funded startups, but we've made a lot of progress in a very short amount of time.
Okay, I think I'm live.
Hey, there we go, technology. Hey, next question. Gina, this is for you as a follow-up. So we've been talking about a lot of the state of your respective companies and how you're doing some traditional things in an innovative way with technology and some entirely new and different things, either because of technology or more because of how both of you respectively believe that there can be a better way to treat patients as consumers for the experience. What do you think the future holds for telemedicine and virtual care post-pandemic? And then tell us a little bit about companies other than Kindbody or Parsley that you think are doing something new, interesting, or exciting.
Yeah, Kindbody started where Parsley and the rest of it, we started in the D2C business because it was easy and lots of low-hanging fruit. Again, trying to work with the payers or the large self-insured employers, they're just big. And you have to have data, you have to have clinical outcomes to make your way into that. The other thing that you have to do is work your way into the payer system. So in the beginning of Kindbody, the majority, almost 100% of all of our patients were direct to consumer. And then that shift turned to managed care. There's a generous mandate now in New York. If you are a fully insured employer, must cover 3 IVF cycles. So 4.7 million new New Yorkers now have treatment and coverage that did not have it previously. Now, self-insured employers do not have to abide by the state mandate, but what that caused is a lot of people who did not have coverage previously now have coverage, which has been great for us. So we love the payers. And again, that's why I'm telling you, they are shifting, they're getting there. They know member experience is important. But when we think about what the future of the industry holds for Kindbody, it is selling directly into the employers. So the folks that are selling into the employers today are those historical, traditional legacy solutions. So the carriers, it's also kind of any other intermediary, but they're not in the doctor business. So when we're selling directly into the large self-insured employers, we are the only doctor group doing that. The rest of them are these intermediaries. So we're delighted to share we have 32 new employer customers launching January 1st, a very sizable 85,000 member life group launching April 1st. And I think, what we see in reproductive health is it used to be that fertility was a nice to have benefit. Maybe the tech companies, used to offer egg freezing and IVF. Today, because of the macroeconomic trends, more and more people wait to get married. You have more same-sex marriages and family building than ever before. Single moms by choice, single dads by choice. The industry is really, really growing. And that member population is putting pressure on the HR teams that this is no longer a nice to have benefit. It is a must-have benefit. And it's not just for the tech companies anymore. It's for media companies. It's for agricultural companies. It's for the gamut. So we think the future, again, is a lot of opportunity about removing waste from the system, going back to the way healthcare was designed, and that is from the payer, but the payer this time is the employer, from the employer to the doctor and the doctor to the patient. And today, that 1, 2, 3 people is about 12. And you can imagine if you remove the other 9, what you do to healthcare costs. But it's we guarantee about a 30% savings every single time. And you can start to understand it when you pull out these intermediaries, how you get to those tremendous cost savings. And if you're a large employer and you're spending $80 to $100 million a year on a fertility benefit, what a 30% savings looks like.
Nate, you want me to answer?
Yeah, go ahead. Just because I'm on video, please keep doing it.
I figured I could tell that you were trying to take yourself off mute. Again, these are the things we've gained from COVID. So your questions were, what does the future hold? The first, I think that with, frankly, COVID, we just see that there has been an increasing adoption of technology and digital health, both on the member side, but actually more importantly on the provider side. This is something Gina and I had a call a few weeks ago when we were talking through. You see that providers, before COVID, there was a fairly substantive group of people on the provider side, and these are doctors, who did not believe that telehealth would be able to replace or augment the in-person experience to the same level as it does today. And I can just say in terms of my staff, we're the largest practice of our kind in this country. We have over 50 clinical staff. And these folks, there were a number of them who really did not want to practice virtually before COVID hit. And now in the last 6 months and frankly, the next 6 months that we continue to work from home, I think you're going to see that there's an increasing comfort and adoption on the clinical side that has been very, very slow to be adopted historically. And this is just the kick in the can that it took to get the thing started. So I think that's one of the most important things here is that clinicians are going to be more comfortable prescribing down care to telehealth-like services. I know a few of you in the chat have been asking about hospitals and kind of where this works in the hospital space. I haven't had experience there. Obviously, I can say anecdotal in my thoughts. But I do think one thing that you will see is that in the next 6 months, there's going to be a heck of a lot more focus from hospitals in thinking through how they can manage potential future waves or potential future pandemics, frankly, by being able to bring care down to these types of lower levels that are offered through digital health or telehealth services. It's probably not so relevant for Gina nor my company, Parsley nor Kindbody are necessarily well positioned to do digital monitoring of COVID. But I do believe and have seen a lot of centralization around that side of the market, both in terms of testing, but also at-home support. So I do think you'll see, first, this increasing adoption on the clinician side with telehealth. Second, hospital systems are going to increasingly work and partner with players in the digital health space to service COVID members. And then finally, I think as you see employers who are increasingly going virtual for extended periods of time, I think Tesla announced that they're going to go virtual forever, or some portion of their team will. Facebook and Google are going virtual until July. There's going to be a lot more employers who historically have been working with companies like Crossover or Eden to offer on-site solutions who need to move into more of a virtual offering to cover their employees who now are located across the country versus at one flagship employee or a location at like Google HQ. So that's going to mean a heck of a lot of innovation and change in the employer space, which congrats, Gina. That's huge. I can't believe you've had such a good 2021 employer push. That's really exciting. And I live here in New York, so I'm a beneficiary of the new laws. It's just awesome to see. But I think you're going to see a lot more innovation on the employer side, specifically with digital health partners like ours, and consolidating partners like the Teledongo merger that everyone's been talking about. And in terms of, you asked another question, which we didn't answer, but I'll start and maybe pass it over to Gina. What companies had a really great job during COVID? So again, I was talking to Gina a few weeks ago. I think Kindbody has done a great job. I'm on their newsletter. I get their newsletter every few weeks, and especially during COVID as an essential service, they stayed open. We stayed open too, but you did a great job at addressing a lot of the challenges that women who are going through this sort of member journey are struggling with, especially during COVID with all the uncertainty and anxiety and stress. I think another one just that I've personally seen really innovate and grow and adopt quickly is Whole Foods. I think Whole Foods has done such a good job at mastering the pickup and delivery, especially in urban environments like, frankly, New York, where they have deep penetration. And the member experience they give is seamless. They collect the data from each encounter and then are able to smart suggest future options for you. They're reliable as heck. So I think that that's one that I've seen just innovate and become increasingly important, as obviously given the context from all of us working from home as a provider of food. So Gina, how about you? What have you seen that's impressed you?
We talked in the pre-call, but I'm sticking with my same company that I'm watching and that I really like in the last 6 months, and that's Peloton. I just think John Foley and the team have done an extraordinary job of adapting. When I suggested them 3 weeks ago, they had not rolled out this lower cost bike. But I do think in order to build scale in this country, we have to be able to address social inequity, and we have to be able to provide care for everyone. And historically, whether it was spinning or fertility treatment, it was for the top 1%. And morally, we think that's a problem. And so, Nicole, thanks for the nice shout out with Kindbody. But we're doing a lot to address social inequity. And it just goes back to providing a member experience that they enjoy. Our clinicians are incredibly diverse, so is our patient population, but we take a lot of pride in that. But again, I think Peloton has done, their instructors are diverse, the music choices are diverse. It's a solution built around me. I can work out whenever I want instead of going to a 9 a.m. spin class. So it's been great.
Well, I want to thank both of you personally and directly, Gina and Nicole. You really shared some deep insight, stuff I don't typically hear. You went beyond the talking points, and I think that was really what our hope was. And I'm very pleased with and grateful for you to have spent your time sharing your insights and knowledge with us. For the rest of the attendees, thank you for joining us at the 2020 CEO Innovators Roundtable webinar. If you would like, our next one is on October 28th. Where we'll discuss what's happening at Mayo Clinic Platform, which will be a conversation with John Halamka. He's a physician and president of Mayo Clinic Platform and helped launch their new hospital at home virtual care model earlier this year. Thank you very much and stay safe.
Yeah, thanks, Nate.
Thanks everyone.
Nicole. Thank you.
Thanks, Gina. Bye, guys.